Hello, everyone. My name is Maureen Tierney. I am the chair of the Department of Clinical Research and Public Health and the Associate Dean for Clinical Research and Public Health at Creighton University School of Medicine. And today we're going to have the first of a series of talks and discussions to celebrate Nebraska, actually national as well as Nebraska Public Health Week. We are really honored and privileged to be able to have as our first speaker to start things off for this week, Dr. Margaret Hamburg. Dr. Hamburg and I go way back. We were actually interns and residents together. So we've known each other collegially and as friends for, I'm not going to say how many years actually. And but so we maybe slip into Maureen and Peggy during the midst of this talk as opposed to titles. But I am really privileged to have her as a friend and colleague because what she's done during her career and how she's contributed to public health, not only nationally, but globally, is really extraordinary. Some of her positions, if I said them all, we would not have as much time to talk, but one of them was being the New York City Health Commissioner during a very challenging time, during some of the first episodes of multi-drug resistant tuberculosis. And her leadership in that was really, revolutionary is a strong word, but I think it would fit. She was also the Assistant Secretary of Health for Planning and Evaluation under President Clinton. So she was appointed by President Clinton to that position. And in that role now would probably have the title of Assistant Secretary of Health for Preparedness, but she created the first preparedness and biodefense plan for US DHHS during her time there. And then most people may know Dr. Hamburg is because she was President Obama's first commissioner for the FDA. As I said, there are many other positions and roles for the Association for the Advancement of Science, National Academy of Sciences, but at present, she has two major roles. The acting vice president for biological programs and policies at the Nuclear Threat Initiative. And she's also the new chairman of a new commission that's devoted to looking at a national public health system. And with that, I'd like to turn it over to Dr. Hamburg to start to talk. And the first question would be, is why this new commission on a national public health system and what does it hope to achieve?
Well, thank you so much. I'm delighted to be part of this discussion and part of your celebration of Public Health Week, and also to recognize the important leadership, Maureen, that you're bringing to Creighton University, and the importance of really creating a linkage between clinical medicine and research and public health. So we've got a lot to talk about. I'll start first with this new commission, which I think is very important. And it really is trying to define how in this complex modern world, we can really strengthen and extend the public health system in our country and really better define, first, the national role in public health programs and policy, but how that national leadership and functions, including, of course, funding, but other aspects of public health from guidance and research and science to the important on-the-ground activities, training activities, and workforce development activities with our system of public health that unfolds at the state level, at the local level, and of course, the need to connect internationally as well. So we are trying to really respond to the fact that the COVID pandemic has shown a very harsh light on public health and revealed gaps in capacities and function that have been longstanding due to underfunding and underappreciation of the important role of public health, but have become, much more visible and, of course, very significant during COVID-19. But it's not intended to be a look back at, what went wrong with the response to COVID-19, but rather certainly what lessons are learned, what was revealed, but looking forward and recognizing that pandemics are and will remain a serious threat, along with local disease outbreaks and managing endemic infectious disease. But there's so many other pressing public health problems before us, from chronic disease issues and hopefully strategies to prevent and reduce the burden of that disease, to opioid addiction, to tobacco use, to the growing concerns around the linkage of climate change and health, and the list goes on. So we need a strong, well-functioning public health system in this country. This commission is really focusing more on the US national system, but recognizing it has to be part of the global public health architecture as well. But what can we do to make sure that public health has what it needs in this, complex and demanding environment, that we are thinking about public health not in isolation from other activities, other disciplines of medicine and other components of government or sectors of society, but really public health as a critical leader and point of orientation for something that matters to everyone, no matter where they live, no matter where they work, no matter what they do, no matter what their origins and what their interests are. Health is fundamental to all, and public health is about promoting and protecting health, preventing disease, and we really need, this is a critical time to step up as leaders in public health and practitioners of public health, and also to ensure that our country has the commitments in a sustained way to a strong, robust, cohesive public health system.
Peggy, I think it's so important to do that look now, because I think there's a tendency in some arenas to say, okay, let's just get back to normal. Let's kind of get back to the way things used to be. And, the way things used to be were that up to 60,000 people died every year of influenza. And we also were pretty slow. And if I think about 3 years ago, and we would put out our influenza statistics, and they would be put out on a weekly basis on usually a Thursday or Friday for the week ending the preceding Thursday or Friday. And so we really weren't able to react as much in real time as we could. So one of the, you're right, we don't want to look back completely critically, but you want to look back, what were the pros and what were the cons? What did we learn? One of the things is the information capacity of most state health departments has expanded dramatically. And so having a commission like this to say, let's not lose that data capacity. Let's utilize that in a positive way going forward so that we can be healthier.
Well, absolutely. And of course, you've put your finger on one of the critical areas of concern for our commission, which is data and information, because we have to have that in order to drive sound decision making and to be able to communicate clearly to all of our stakeholders in public health, including, importantly, the public. And we saw with COVID that there were these disconnects. I mean, there was first a problem that many health departments, especially the smaller ones, weren't adequately resourced to have the kind of information technology they needed to just collect and manage data. But there also were gaps in authorities to collect certain kinds of data, and different states were collecting different information in different ways, in different timeframes, which made it very hard to get the kind of snapshots that we really needed to understand the nature and scope of this unfolding pandemic, and where to target resources and what really needed to be done. And then on top of it, there was a lot of concern about what was the CDC's role. And people kept complaining that why isn't the CDC requiring hospitals to report data on a daily basis, because that information was needed to know about hospitalizations and deaths, et cetera. But in fact, there are gaps in authorities for the CDC on a national level to do certain things like that. So we really have to take a clear-eyed look at all these issues, from the infrastructure support and building capacity to creating the kinds of alignment amongst different reporting systems, and defining and empowering, the role of CDC, especially in a crisis. And, it comes back to the silo question. It's not just the public health agencies working to collect information. It's a real partnership with the healthcare system to be reporting information into public health, and public health reporting it back to the healthcare system to make informed choices and take appropriate actions. And then, of course, so much of what's important for health happens outside of the healthcare system. And so there are many other important partners and stakeholders to be both getting information from, providing information to, and really working so that everyone is pulling in the same direction, especially in emergency. But that's important for health day in and day out as well.
Another area where I think there was improvement, although there's a lot more improvement that needs to happen, is public health messaging on every level. And, this really, COVID really pulled us into making sure that community level messaging was better than it's ever been. And again, obviously still a lot of areas to expand, but in terms of services, like making sure that there was testing locally, in all areas, that they were at times when people could go. If you're working and you can't take time off to actually go, is it there? Actually having testing in food processing plants, having community, meetings where you had translators. In particular, there's a large Burmese community in the northern part of Omaha, and where they speak Karen. And so having communication sort of settings where information could get to every single community. But I think being able, so the concept of educating with data to local communities, as well as sort of across authorities, is something I think we need to improve from.
Right. And I think COVID, really was a powerful reminder that even though we in public health think we're wearing white hats, and of course, everything we do is to improve the lives of the public, and of course we should be trusted, there are reasons why people don't always trust authorities. Both, sadly, there have been examples where authorities have not treated people with the respect and with the ethical actions that, hopefully we all would adhere to. The Tuskegee experiment is, of course, one profound example of that. But also, we live in a world where there's, a lot of sort of questioning of authority, of government officials. And, sadly, the public health workforce during COVID has been battered in many ways. But it's really important in any context to sort of recognize that there are other trusted messengers in communities besides government officials. I think public health workers and physicians and other healthcare providers do still tend to garner a lot of respect and trust, but we have to earn that every day in terms of being trustworthy in our messages and our action. But also we need to engage, other important leaders in communities to help convey critical messages and to help implement important programs, whether it's, the barber or the local mayor or the elementary school teacher. The more we as public health professionals can really reach out and engage in communities to provide clear, compelling messages and to embrace other messengers as needed, is absolutely crucial. And I think that's been one of the challenges with vaccine hesitancy, is that you don't necessarily want a talking head on national TV saying you should do this, and if you knew as much as I do, you'd understand why. It's the person down the street that's had the vaccine and can say, I was really uncertain, but I got it, and I had a few symptoms, but it wasn't so bad. And I'm really glad I did, because my aunt so-and-so actually got COVID and was really sick. And, so we need to think, really differently about our roles and responsibilities. But I think also I have to say that this is a time for those of us in healthcare and in public health to really understand that this has been an unusually challenging time. The work you're doing, has been more vital than ever before. And even though it isn't always accompanied by the kinds of shows of appreciation that would be wonderful, I think there is no doubt that the American people, appreciate what has happened in terms of healthcare providers and public health professionals stepping up to the plate to work for the benefit of all.
And I think that's so crucial to address. It's not part of our discussion today, but it's an important discussion that is being had, I think, more and more as a result of the protecting the mental health of folks in healthcare professions and public health, because they have been strained beyond most anyone's expected capacity, and I think continuing to support that and is something that I think we all really want to do.
It's so important. It's so important.
I want to pivot to a topic that I know is near and dear to your heart. And the last time, and Peggy and I aren't even in person today. We're about 1,500 miles apart. But the last time we did see each other was actually at an infectious disease conference in Washington, D.C., when she gave one of the keynote addresses talking about pandemic preparedness and the work that an organization that she's very much involved in and in founding, which is called CEPI, on pandemic preparedness globally. And so I'd love to ask you to tell us a little bit more about CEPI and what it's doing.
Sure. Well, it's a great pleasure to talk about CEPI. I'm on the board and I chair something called the Joint Coordinating Group for CEPI. And I'll talk a little bit more about that. But CEPI is a fairly new organization that has really come into the forefront during COVID and the demands of this global pandemic. But it was started actually after Ebola, when it was recognized back the West African outbreak in 2015. And it was recognized that the response to Ebola was compromised by the fact that we didn't have an Ebola vaccine available, and that studying an Ebola vaccine candidate or candidates in the midst of an ongoing outbreak was very, very challenging, and in a country that had an underdeveloped capacity to do clinical research as well, both in terms of trained researchers, infrastructure for doing clinical trials, and public understanding of what clinical trials are, why you do them, and what it means if you participate. So, I was at the FDA at the time as commissioner, and we were able to move forward in some remarkable ways with some Ebola vaccine candidates, and creating clinical trials. But it was a huge challenge, and a number of philanthropies, actually, the Gates Foundation, the Wellcome Trust, and some others, along with a couple of governments, came together and said, let's not ever be so unprepared again, because Ebola was tragic and devastating in West Africa, but it didn't pose the kind of global threat that some other pandemics could and likely will cause. At that time, no one was thinking that COVID-19 was right around the corner, but CEPI was created and the decision was made. It's called the Coalition for Epidemic Preparedness and Innovation. And its mandate could and perhaps will be broader than just vaccines, but the decision was made focus on vaccines initially, because that's such a critical part of managing and preventing pandemics. The initial sort of mission and scope was to identify a number of viruses or organisms of pandemic potential and develop candidate vaccines. Really up until early phase 2 was the idea, but then also create a framework for studying those candidate vaccines should a new pandemic emerge. And so it was surprisingly prescient for some of the needs of COVID-19. And this joint coordinating group that I mentioned was really an effort that CEPI from the get-go recognized that it doesn't do all that much good, even if you have great science, to, number one, develop a vaccine part way, but not have the partnerships, the tools, the resources to take it over the finish line, if in fact it has promise, and to actually get it into people's arms. So while CEPI, really was created and remains predominantly focused on supporting research and vaccine candidate development, it really wanted to do it in the context of the ecosystem that has to support the full development, from the recognition of the need potentially for a vaccine and what it should look like in terms of use, all the way through the R&D, the regulatory, the procurement, and ultimately the delivery to people. So this joint coordinating group brought together people from all those domains of activity, including UNICEF and the Global Alliance for Vaccines and Immunizations, that is a major purchaser of vaccines for the poorest countries in the world, Médecins Sans Frontières, which is always there in a crisis delivering vaccines. It brought together regulators from different countries to try to align that important work, to try to streamline the clinical trial design process and the regulatory review and availability process, and importantly funded research in a couple different areas. Interestingly, CEPI identified MERS as one of the areas for vaccine development pre-COVID-19. And it was criticized by some in the public health community because they said, it's not really a disease that is likely to cause a global pandemic. It tends to be episodic and geographically limited, and the best approach to MERS might even be a camel vaccine, not a human vaccine. So why are you focusing on that? Turns out that the MERS vaccine that CEPI was funding was a Moderna mRNA vaccine against a virus in the coronavirus family. And CEPI was the first to pivot when COVID-19 emerged. And by the end of January, after the genome was posted, CEPI was funding Moderna to create what is now the mRNA vaccine that so many of us know about, and many of us have had. So, that I think, is a quick description of CEPI and its work. It's now, importantly, I'm sorry I'm talking so much, but it's important and I care about it. But it also has been part with the organization Gavi I mentioned, of something called COVAX, which was created really as the pandemic was unfolding, to try to create a mechanism for countries rich and poor to invest in vaccine development so that we could achieve greater vaccine equity around the world. It was a challenging task because so many of the richer countries wanted to develop their own vaccines and wanted to have their own contracts, bilateral contracts with manufacturers to get vaccine, and they weren't as interested as a first tier because of their national concerns about helping invest in a pool to create vaccines that would be available to all countries. But it has proven to be a very important component of the global vaccine supply, and an interesting model that will obviously have to be examined and worked on in terms of what it might look like as we think about and prepare for future pandemics. But that has been another really important role of CEPI, coordinating some of the vaccine development and availability issues for the globe. And then the last thing that I'll just say about CEPI is that it also, watching what happened with the COVID-19 vaccine development, has made a commitment to really looking at ways that in the future we can more routinely speed vaccine development. You probably know that, routinely in the past, vaccines took 10 to 12 years to go through the whole R&D, clinical testing, and then availability process, including, importantly, the scale up in manufacturing. The fastest pre-COVID was 4 years, and that was for mumps. COVID, notoriously was less than a year from when the genome was first posted and the virus emerged in China to vaccines in people's arms. And that was because, of an extraordinary effort. It built on a lot of earlier science and investments as well. But it certainly showed us that we can move more swiftly, sometimes, taking financial risks in the process. But if everybody in this ecosystem for innovation is working together, and importantly, it is agreed that the product is addressing, a critical public health need, we can do things very differently. And I think, as I look forward, one of the great challenges is that we shouldn't think about public health need only in the context of a catastrophic crisis like COVID-19. We need to be looking at what are the really important unmet public health and medical care needs today, and making sure we have that same sort of concerted commitment and R&D effort to get the products that we need and to get those products to people. And just as an aside, and then I will stop talking, that's why the department, Maureen, that you're now heading is so exciting to me, because it creates a natural linkage between clinical research and medicine with public health. And they shouldn't be two separate professional practices and areas of activity. They need to be linked. They need to bring the best scholarship and science, and they need to bring the kinds of passion and professionalism that I know you bring to your work and to this new department.
Peggy, you shouldn't apologize sort of for talking, because that's why you're here. Actually, that's why we wanted, is to hear that perspective. As I said, I remember so vividly, it was you, the other keynote speaker at that conference was Tony Fauci. And both of you talking about in vaccine development and candidates. And I recall that one of the the candidate, diseases was going to be coronavirus. And so, thankfully, I mean, that clearly helped, I think, to speed things along. I think, one of the areas that you importantly addressed was, the concept of vaccine equity globally. And I think that, for folks to understand a little bit more about how we can achieve that, I think there's some misunderstandings. I think there's some places that have more vaccine than we thought they did, and then some places that have less. And I'm wondering if you could just talk a little bit about, besides what you've already mentioned, some strategies to achieve that.
Yeah. Well, I think global vaccine equity in the face of a pandemic is absolutely foundational, and that we really have to continue to address it, even as we see the shadow of COVID-19 beginning to lift in this country. And let's hope that, in fact, that will be true, but we should never become complacent. And we know that the burden of disease in this country and transmission, does remain quite significant. But around the world, there are populations that are very at risk and don't have access to vaccines. And the very nature of a global pandemic is that it involves a threat that is global, and that anyone in any country is really only as safe as the weakest link in terms of public health and medical management of the disease, that we will remain more vulnerable in this country, even if we want to look at it only from what's in our best interest as a country perspective. I think there's a huge humanitarian responsibility for us to care about what happens to people and their health in other parts of the world. But even if you put that aside, it's in the vested interest of US citizens and our government to care about getting vaccine to peoples all around the world, because as long as there are pools of unvaccinated people, as long as the virus continues to circulate, we are at risk for the emergence of new variants, potentially variants that will continue to infect people within our borders, variants that might actually be more successful at evading the immune protection of vaccines, and could potentially cause more lethal disease. So we are not safe anywhere until we really address the public health and medical needs of people everywhere. And I think one of the things that was unfortunate watching the COVID-19 pandemic response unfold was that our country and other countries in the Western Hemisphere, did notably take the posture, and it's understandable, and especially as a government official, I get it, but the notion that we have to address the emergency in our own country first, and then we can really turn to the international. I think that reflected both wishful thinking that the vaccine was going to be the magic bullet, and those of us that understand something about vaccines knew that that was probably unlikely, and that it wasn't really going to fully protect against ongoing infection and other things. But it was hard to argue when the clinical trials, the phase 3 trials were coming out, and the extraordinary levels of protection against serious disease and hospitalization and death. I never dreamed that these vaccines would have such high levels of efficacy. But it was hard not to be optimistic that if we could just get this vaccine into people's arms in this country, then we could, really focus elsewhere. But especially for the United States, with our wealth, our leadership in the world, and the robustness of our biopharma industry and our science, I think, one mistake that was made was that we waited too long to really address the international aspects of the pandemic. And we missed an opportunity really almost, in terms of sort of science and public health diplomacy to provide leadership on that international stage.
That kind of flows nicely into the next topic that I wanted to talk about is, when you have large movements of refugees in emergent situations, there's obviously a lot of disease related issues and other issues that happen with that, and epidemics that occur in that setting of crowding and inability to monitor disease as well as you do in the normal scenario. But right now, who knows exactly what the numbers of movement, clearly at least 2.5 million, if not 3 million refugees into all of Eastern Europe from Ukraine, a country that has a lower vaccination rate than most of the Western world, perhaps a higher disease rate than many countries. But what are some thoughts that you have about, in general, particularly about COVID, and in this particular, what we think is may happen as a result of this refugee migration, and then just some other points in general about how we can, what are some of the issues that arise with the refugee migration from an infectious disease and public health standpoint, and what, if anything, we can do better in that in the future?
That is really an important and timely question. And it's not just the refugee situation in Ukraine that should draw us as public health professionals to the question of refugees, but the fact that for many different reasons around the world, we already have some 84 million refugees coming from conflict areas, from areas where they were fleeing persecution and human rights abuses, or from extreme climate related events and other things. So we really have to recognize that refugees is one of those areas that really is a public health challenge, and that it is an important area for our work and attention. It's crucial, just now narrowing in a little bit more on Ukraine and the refugees going into neighboring countries in Europe. These are individuals who are perhaps under vaccinated, and COVID is circulating, and BA2, I think, is a dominant strain there. And, we're all watching that with interest and concern. But so these are people that may be at risk for COVID disease and spreading COVID disease. There's also concerns about tuberculosis, including drug resistance. There are some polio cases in Ukraine, actually vaccine related, under immunization from childhood preventable diseases because programs got disrupted during COVID and then during the conflict, of course. So there's a lot of issues around vulnerability to that set of infectious diseases that create vulnerabilities for others as well. There are the issues, you move people into these refugee camps, they're crowded settings, that creates issues not just for communicable disease of the respiratory type and others that we're talking about, but more acute problems from poor sanitation. There are problems of access to clean water. Of course, there are also issues of access to adequate food supplies and quality food. So a lot of issues with respect to food and water safety and security. Then there are the issues that Ukrainians, like all of us, have chronic medical needs or on medications. They have issues that need to be managed day to day. They have acute medical problems like heart attacks and strokes as well. And there are, kids and adults that have cancer that are in the midst of treatment. How do you manage all of that in a setting where people are, just picking up and leaving? They don't know what to bring. They don't know how long they'll be gone for. And they're coming into settings where their health records aren't available. The expert care they've gotten, the meds may not be available. And there may be emerging new disease threats that need to be managed. So that is just a huge, huge challenge with near and long-term consequences for those individuals, for those who are helping to provide, care and support to them in the refugee camps, and potentially, for others well beyond. So again, it's an area that we all need to be paying attention to, not just watching on TV and feeling sorry, but thinking about what are the things that we can do, either supporting through donations, big or small, to some of the organizations that are working with these refugees. But also, I think it is an area where schools of public health and programs in global health, really should be thinking about how are we going to address a very, very significant problem today that's only going to get larger. The estimates for what climate change is going to bring in terms of refugees are extraordinary. So I'm glad you brought it up. It is an area that doesn't tend to get the focus that it really needs and deserves in public health discussions, but it needs to be full square on our agenda.
I'm glad you sort of made that kind of segue into programs in global health. And, as you know, I started my educational journey at a Jesuit institution at Fordham in my hometown, and am now back at a Jesuit institution. And so I've often said to my colleagues at Creighton that I feel I've come home. And Jesuit institutions, are imbued and founded on, principles, on some of the major principles of Magis, of Cura Personalis, so the care of the whole person, always trying to do more, and then men and women for others. And, our public health program is just beginning a global health promotion concentration. And so in addition to healthcare ethics and healthcare management, we're going to be trying to educate public health professionals in global health promotion, and with a particular program called the Arube Scholars, which will be educating physician epidemiologists to deal with global health issues. And so, I think the last thing that I'd love for you to sort of talk about is words sort of encouragement and advice for folks who are entering public health as a career, and particularly those entering public health or global public health as a career.
Well, I think it's so exciting to hear what you're doing and the opportunities for people early in their careers to have the sort of training and exposures that will make them really successful in doing global public health. I have to say that I think there are few career paths more rewarding than working in public health and medicine, and importantly at the intersection. People have to listen carefully to what they really find rewarding and where their passion is. But there is no doubt that careers in public health and the growing set of challenges and opportunities to make a difference on the global level, really, sort of call out for the next generation of practitioners and leaders. It's interesting to me, as we're talking, Maureen, to reflect that both you and I really started out on very traditional academic medicine tracks. I think both of us thought that we were going to work in some research university, we were going to take care of patients, we were going to do research, and we were going to teach. And both of us, the more we learned, the more we did, the more we were drawn into the world of public health, thinking not just about individual patients and what happens in the clinical setting, but also all of the things that influence people and their health, and all of the different settings in which training in medicine and science and public health can make a difference. And it takes you to very different places professionally. For us, into the world public health practice. It also, can take you, all around the world, which is really exciting and inspiring, and so much to learn from people around the world that informs, our public health practices, but also the difference that can be made. And I think this, we touched on it a little bit before, but this is really the moment when we have to have people trained with just the kind of training that you talked about in medicine and epidemiology and public health that can really straddle the issues around unmet public health and medical care need. We really need to be thinking about how do you define critical needs, how do you identify meaningful strategies to address them, how do you harness advances in science and technology to make a difference, and then importantly, how do you engage in the people that actually need these interventions? How do you communicate, as you were discussing earlier, about why this is important and why you either should change your behavior to reduce certain kinds of threats, why you should get vaccinated, why you should take certain medicines, and also working with critical institutions in countries and places around the world and the leaders to make very fundamental changes. I mean, I think one of the things that you didn't mention in my intro, but that I am increasingly working on the intersection of climate change and health, because when I look out across the landscape of public health and medical issues that will really matter in the weeks, months, years, decades to come, it is that intersection, and it's really a powerful one. To be honest, before I started working more deeply in this area, I didn't appreciate all of the health consequences of climate change, and also the contribution of the healthcare industry to climate and environmental degradation. It turns out that the healthcare system in this country has a very, very large carbon footprint, among other things. But being able to think and understand the health aspects of so many different aspects of our life and address them is just so rewarding. And for me, public service was an unexpected path, but really, I found my calling. I loved being able to work in a way where I felt that I was really able to influence policies and programs that greatly amplified my impact. When I started as health commissioner in New York City, my great aunt Winnie, who was sort of like a grandmother to me, was very upset because she was proud of the fact that I'd gone to medical school and I was a doctor. And she said to my father, why is she throwing away her medical career, to be a government bureaucrat? And he said, well, don't think of it that way. Think of it that instead of having, a couple of patients, she now has 8 million. And, and I think we all have the opportunity to be doctors and healthcare providers and public health practitioners for the world community, whether it's doing research, at Creighton that can be translated into important programs and policies and make a difference in people's lives, or it's actually, getting out and pounding the pavement or getting into the fields in some remote part of the world to practice or do research. So it's, to me, it's just an enormously exciting time. It's a challenging time, but I think that the fields of public health, medicine, biomedical research and innovation, and the translation of science into programs and policies that really matter for people has never been both more exciting and more robust.
Peggy, I can't thank you enough for sharing your time, your wisdom, and your enthusiasm for the important work that's ahead for this, next generation of public health providers, practitioners, whether they're solely devoted to public health, whether they're nurse epidemiologists, physician epidemiologists, you're right, researchers, vaccinologists. But I think that, what you've shared with us in terms of the impact really one individual can have in all these areas and the benefit that furthering public health and its intersection with other areas in our society, just how important that is. So we're really blessed to have had you here this afternoon. And thank you so much for sharing with us today.
Terrific. Well, it's been a great pleasure. It's been exciting to learn about what you're doing and what's happening at Creighton. And I look forward to getting updates as time goes forward.
And actually meeting in person
And
in the
meeting
near
in person.
future.
Yes, indeed.
Okay. Thanks so much.
Thank you.